Thank you, Rachel, for your introduction. And thank you to the organisers of this event for inviting me to speak to you all today. I'm here to talk to you about my passion, which is the protection and promotion of good general practice. We know this works. It's the system that's broken. Now, many of you here today are from the business world, so I'll start with a quote from Tom Peters, whose book, In Search of Excellence, changed the marketing industry. Tom Peters says that if you want long-term success in business, you need to nurture relationships with your customers, because listening carefully and often to your customers enables you to meet and exceed their expectations. And this then improves your product, increases innovation and productivity. Why would this matter in health? I think it's pretty obvious. If you just replace the word customer with patient, then the quote still applies. Listening to and knowing our patients is the business of GPs. I'm speaking to you as a specialist GP who, as Rachel mentioned, also built a practice from scratch and grew it successfully over 9 years. I'm really aware of the issues and opportunities we have in primary care. I ran my practice on the basis of providing the best quality continuity of care that we could. You could still get in to see me as your GP within 2 days for a non-urgent appointment. But this goal was getting harder and harder to achieve with each passing year. What I do know is that primary care delivered in this way works, but the systems made it nearly impossible to do this. Overall, what's clear to me is that policymakers need to value specialist GPs because we are the beating heart of primary care. The present system is not working for anyone, that's pretty clear. But a long-term plan which uses specialist GPs to provide continuity of care will allow us to turn things around. It's taken over 20 years for us to get into this mess, but I hope it won't take quite as long to fix it. So when I refer to GPs, I'll be talking about specialist GPs who, like other medical specialists, are highly trained doctors with a recognised fellowship from the Royal College. It's our broad and deep knowledge that allows us to provide whole-person medical care. And we do this whilst also managing the complexity, uncertainty, and risks associated with the continuous care we provide. And of course, we don't just treat individual patients. We're seeing them in the context of their families and their wider communities. In fact, we're embedded into the communities we serve. It sometimes makes going to the supermarket tricky. I can't remember the number of times I've been accosted for medical advice while I'm trying to do my groceries. But it's such a privilege to be a constant in people's lives, and that's what we're always reminded of. We've all worked in hospitals as well as part of our training, and it's this knowledge that allows us to support patients to navigate the crazy hospital system. And remember, we don't just treat illness, we prevent disease. We've got the ability to change the future. No GP, and there's lots of us here in this room, can tell you how many heart attacks, strokes, or deaths by suicides we've prevented over our careers. But we know we do all this because these and other poor health outcomes are much worse when you don't have enough GPs. So I hope by the end of this talk, you'll understand the value add of specialist GPs and why the health system simply can't afford to lose them. This is my daughter when she was 2. She's extremely excited that she gets to be part of this talk. So being a GP, the reason I've got this picture is being a GP isn't child's play, but maybe we make it look too easy. The ongoing care we provide over time is what sets us apart from other specialists, but perhaps it's the fact that we are based out in the communities and not in shiny hospital buildings that makes it easier for policymakers to take us for granted. But we know that our communities need and value us though. And a child's view of a GP is quite pertinent, because they see us as their doctor. And mummy and daddy takes them to the doctor when they're sick, and we make them better. In fact, I think all our patients see us that way. We're their doctor. General practice is, and always has been, localism in health. I'd now like to share a patient quote with grateful thanks for the family for allowing me to use it. I think it illustrates what we do from a patient's perspective. In the space of a couple of years, the different members of our small family of 4 experienced a cancer diagnosis, sectioning under the Mental Health Act, stage 4 endometriosis, rape, Graves' disease, and 3 major surgeries. We leaned heavily on our family doctor and relied on her to help guide us through what were extremely difficult times. Being able to regularly see the same GP who understood what was happening in the wider family context genuinely made this time so much easier for us. Not having to retell and re-explain the history every time we needed medical care lessened our stress significantly. So this is what we do. But these are the conditions in which we do this. This is what a typical day for me looked like. You can see that we've got a high patient load, and we're also increasingly supervising and supporting colleagues and reviewing their patients as needed. One of the things I found was worsening was managing my inbox, which would often have at least 150 new results a day. And it would include results I had from tests I hadn't even ordered because they were coming from my secondary care colleagues. Fortunately, there is a way of sorting this bit out, and I'll talk to you about that later. And that's what we do in a typical week. So, the powerful patient quote I shared with you shows how complex our work can be. And there's a great study from 2015 to back this up. It analysed 14 specialties using data from close to 1 billion patient visits. And it looked at factors such as presenting complaints, diagnoses that could be made, the treatments available, and the time you've got to deal with all of this. And general practice came out clearly on top. We are the most complex specialty in medicine. I don't think people really understand that if you're not working in it. So what does this mean in practice? Lots of patients come to us with chest pain. And they obviously are worried, as we all would be, that they're having a heart attack. But chest pain could be so many other things. And if you don't have the proper medical training, all you're going to do is end up organising unnecessary tests and sending patients off to hospital when they don't need to go. So, how do specialist GPs do the nearly impossible every day? The key is applying our specialist knowledge and skills in the context of the doctor-patient relationship, when it's then founded on continuity of care. You need all these things to derive the optimal value of GPs. So, in short, we save lives, extend lifespans, and save money. And we've got 60 plus years of data to prove this, so Professor Levy is very welcome to it. What we don't have is, in New Zealand, an easy way of extracting that data. So Maria, maybe you can help with that. So we use continuity of care, as I explained. Continuity of care in this context means the relationship a patient builds with their specialist GP. It's literally the superpower that GPs possess. But the system is like our kryptonite. Continuity has been termed literally a matter of life and death, because it is. If you have continuity of care with a GP, you're less likely to die of a heart attack, stroke, cancer, or diabetes, regardless of whether or not you smoke or are overweight. If you have continuity of care with a GP, you're likely to live longer, regardless of your overall age, to begin with, ethnicity, or wealth. If you have continuity of care with a GP, you'll feel happier about your health. And the evidence shows that adding GPs to a population yields more health benefits than adding any other physician group. I think it's absolutely vital that we understand and accept this, because none of us think about getting older or getting sick, but it happens to us all. So what the evidence is showing that no matter how well off you are, having access to a GP improves your health outcomes. But it doesn't stop there. Continuity of care also reduces healthcare costs, visits to emergency departments, and hospital admissions. Even with the recent expansion of virtual healthcare, continuity of care is still the key to reducing costs. So, there's the numbers there. A US study showed that for every dollar spent in primary care, there was a saving of $13 down the line. And in New Zealand, due to the economies of scale, those savings are likely to be higher, but it's very difficult to measure those. Conversely, another US study showed that patients with the lowest continuity of care cost the system around 14% more than patients with high continuity. So I know I've gone on about it, but I hope it's clear why we can't move forward without focusing on the need to protect continuity of care. I'll highlight just a few factors, and I think when you look at it like this, it's quite obvious about how continuity of care works. So a patient feeling that they know their GP, it's not just something nice and fluffy to have, it's medically important. Because when people feel more comfortable with you, they're more likely to disclose medical issues that they felt they didn't want to talk to anyone else about. This is especially important in the context of mental health, because 40 to 80% of what we deal with in general practice is mental health. But patients don't always come and tell you that that's what's bothering them. Trusting your GP can explain better adherence to medical advice, including prescribed medications. And then the accumulated knowledge that GPs get from seeing their patients repeatedly over time allows for better tailoring of management plans so patients get personalised care. It also means we can work more efficiently because you're not starting from scratch every time, as you would every time you see a new patient. And when you have medically unexplained symptoms such as fatigue, it also helps with diagnosis as it protects against unnecessary tests and hospital admissions. And we've got to remember that GPs accumulate knowledge from every consultation, whether complex or relatively simple. And all interactions build that relationship between the patient and doctor. Finally, a GP's sense of responsibility, although invisible, is key as it drives them to strive for the best for their patients. GPs are themselves actually changed with continuity of care, with the feeling of responsibility increasing 5-fold after 1 year of looking after a patient group. And this only continues to increase further with time. In my opinion, I think this is one of the biggest factors driving GPs away as the weight of responsibility increases as you feel less and less enabled to provide good quality care for your patients. So, GPs listen to their patients and provide the outcomes of comprehensive, cost-effective healthcare. This is our value add, and we've got a mountain of data to support this. So why are things not working as they should in New Zealand? Well, as this slide shows, the terms and conditions under which we as GPs are working are simply wrong, and they've not been comprehensively reviewed since they were introduced in 2002. So if you look back at a typical day for a specialist GP, all of that is unpaid. Or if you're the employer, like I was, you pay for this and the business takes a loss. And then all this in general is not funded enough to cover costs. We keep going because of the responsibility we feel for our patients and the need to train more GPs. But the system can't keep relying on this goodwill. Would you run a business like this? I did, and it was really tough. So, for those of you who don't know, GP practices are paid by capitation, and they've been so since 2002. So it pays practices for enrolling patients, but doesn't consider the number of times each patient will see a GP. It covers roughly only 2.5 visits per patient per year. So it's crazy to think that there's no consideration given for chronic health issues such as diabetes and other factors such as socioeconomic deprivation. So we're simply just not funded properly to look after these complex issues. And we know the poorer you are, the more likely you are to have chronic complex health issues. So you've got a vicious cycle, because you'll then find it harder to access the help you need in primary care, and you end up in hospital sicker than you should have been, and it costs more money to look after you. And it's far worse if you're rural. And this has been mentioned before, we know that the worst off 15% of our population consume 50% of healthcare resources. So this unmet need is affecting us all. It seems obvious to me that health needs increase as we age. Yeah. But as we age, but the top age band finishes at 65. So a GP is paid the same amount for looking after a fit and well, recently retired 65-year-old as they are for their frail 95-year-old mother. GPs also have the skills to do more to avoid hospital admissions. For example, in my practice, we treated women with the severest form of vomiting in pregnancy, hyperemesis. And these poor women would vomit so much that they'd end up severely dehydrated and needing IV fluids. We'd need to do this sometimes 1 to 3 times a week. and in the worst cases, for up to 20 weeks or more. Each visit would take at least 3 hours, for which we were paid about $210. This wasn't enough to cover our costs. Yet if these women ended up going to ED, it would cost the system, we think, around $3,000 each time, because they'd usually have to be admitted. So general practice can do more, but not without support. And I think Cecilia's already talked about the IT issues. They're mind-boggling. It really is. I can't believe that in 2024, we're still relying on fax to get notes from hospitals. Obviously, this has to change, and we've got to get on and do it. I've been saying this, and I think other people have for many years, but everyone keeps saying it's too difficult. We just have to get on and sort this out. Otherwise, we've already got difficult jobs, and we're literally flying blind. And when you combine the lack of unified IT systems with the siloed hospital services, it makes it even harder for patients with chronic health conditions to get the care they need. And it's often we as GPs who have to coordinate patients' hospital appointments for them. So we need the IT systems to also talk between primary care and hospital care. We've got to be careful with how we use virtual health or telehealth. We know, obviously, we were already using telehealth, even before the pandemic, but this has increased a lot since. We've got to use it wisely, because otherwise we're in danger of kicking the can down the road. A recent Canadian study showed that virtual consultations, where the patient and doctor have no pre-existing relationship, are twice as likely to end up with the patient presenting to ED than if the virtual consultation had occurred where there was already that pre-existing relationship. Furthermore, during COVID, when patients in Canada were looked after virtually by their own GPs, there were fewer hospitalizations and death rates dropped compared to the initial model they used, which used providers that didn't know the patients. Again, these examples illustrate the vital role of continuity of care. And I think this has already kind of been talked about, but this is the vicious cycle we're in just one of the aspects of the unmet need from hospital services pushing back onto primary care. So we as GPs can do lots, but we can't do hernia repairs or hip replacements. But maybe that's the plan. I don't know. So what progress has been made? Well, we seem to be we're having a close look at what the terms and conditions are needed for the workforce sustainability, and looking at funding models that can better match the needs of the patients. And like I talked to you about before, about the inbox, some solutions have existed for a while. Health One in South Island is something I'd love to have. It allows GPs to have easy access to patient results and notes, but without being burdened by receiving unchecked results from the hospital. I don't understand why we can't roll this out in North Island. I think it's been around about 20 years. And secondly, I think we all believe localism works. Otherwise, we probably wouldn't be here. But we need easy access to shared data. So again, that we're not flying blind. South Island have already managed to achieve this by putting data from all South Island GP practices onto one shared platform, Te Waipanamu. I think some of the people from that team are here today, so you can ask them about it. Why can't this platform be extended to North Island? There are also some amazing initiatives around the country working with communities to help people engage with and then navigate the siloed health system that we have. Hauraki PHO, National Hora Coalition, and Western Bay of Plenty PHO have funded teams using local connectors to first learn from their communities what they need before helping them to connect to health services. It's sobering to know that often the first thing families need is support from the food bank and connection to the free child dental clinics before they're even ready to see a GP or a hospital doctor. And there's already telehealth services supporting rural communities, and it's easing some of the burden on rural GPs, especially overnight. But to paraphrase Dr. Carl Eggleton, who's a specialist rural health GP and academic, telehealth is a tool and not a panacea. Rural communities want to have the same access to healthcare as enjoyed by everyone else. To achieve this, we must focus on the investment that is required to get more GPs into rural areas. So, the way forward. Actually, primary care teams, I thought they were going to be discussed a bit more today, but they haven't been. So what we talk about with primary care teams is already what we have, but it's working slightly differently. So we've always worked in teams in primary care, but we've always had the continuity of care for the patients being with one GP. It's clear that we can't carry on like this, but we're moving towards a group of patients having continuity of care with a designated primary care team instead, which will consist of GPs, nurses, nurse practitioners, pharmacists, and others. And this could help with medical training because medical students and GP trainees can be embedded into these teams. So it will better support training, and it's better than the current model of one GP teacher to one GP trainee. This delivery model has actually been around, again, Canada, Eric, but there's increasing evidence that it's effective. But for them to be successful, it's dependent on one or two specialist GPs in each team working at the top of their scope, focusing their clinical work on seeing the undifferentiated complex presentations, whilst also overseeing and managing their teams. This is what hospital specialists do when they work with their teams. And great IT systems, as you can see, are vital to support these teams and also link in with the hospital so you can have proper integration of care. So, to sort out the issues in primary care, we need a committed long-term plan with the foresight to know you're not going to get an immediate fix, but if you stand firm, you will get there. All we need, and we need to commit to protecting continuity of care with specialist GPs being the heart of the solution, because this is the most cost-effective means of getting the best outcomes for all New Zealanders. Thank you.
Thanks, Prabani. I can take some questions from the floor. I think I'm still processing that you're receiving faxes from hospitals.
Yep.
Holy. You hear about that, but I didn't actually hear it from the horse's mouth. Mm-hmm. Goodness me. Any questions from the floor, ladies and gentlemen?
How can we tell that it's continuity of care? Sorry, thank you. How can we tell the difference between continuity of care and transferable notes that are really, really detailed? So I can imagine states of the world in which a GP has access to tacit knowledge and there's the trust issues, and that's what's driving things. I can imagine other states of the world where the GP systems across different practices don't talk to each other, nobody's taking notes in the same format, and it's a giant mess.
Yeah.
How do you disentangle those in determining that it's continuity of care that matters?
Well, I guess most of the data has come initially from one doctor having continuity care with the group. But like I said, we've now got those teams. So you've got groups of doctors, but they need to be embedded into a team and embedded into a group of patients. I think in America and Canada, they call it empanelment. So you've got continuity of care between the team and the patients. And again, they're starting to show the same outcomes because I think that's what's proving it's continuity of care. Does that make sense? No. The continuity of care is defined, it's relational continuity, so that's that relationship, but it's also information continuity, which is what you're talking about. But I think you can have informational continuity, but if someone in the team doesn't have that relational continuity, you're missing out.
Any other questions? Yes.
You said there's a wealth of data for GPs. Not just from New Zealand, of course, but internationally.
Yeah.
But let's talk about the New Zealand data. What help would you need from...
Everything.
What kind of data is out there that really cries out to be analysed?
One basic thing is EDI, we're not collecting the data on the effectiveness of general practice. So we have, 21 million GP visits a year, and there's no input of that into the EDI to work out what effects we're having with that. So that would be one thing. That's probably the basic level data we don't have.
Prabani, we've hit our time. We're a little bit over our time, so we will have to leave it there. But thank you so much. Dr. Prabani Wood.